So as I said, it's been a while since we've done VetDojo Rounds, and I apologize for that, but we've been really busy clinically. I took 6 weeks off for long service leave, and then we've been busy on clinics because we lost 2 surgeons, and so we've been trying to cover the caseload. But we are back, and hopefully we'll do this with some regularity, but we'll just have to see how we go. I thought today I would review one of my previous lectures on hind limb lameness in dogs. And I think that there's a lot that happens with hind limb lameness that I think we miss and misdiagnose and that kind of thing. And so I'll go ahead and see if I can find my, let's see, share screen, advanced sharing options. Let me just see where, here we go, bring that up. And so you guys should be able to see the presentation. And so I'll go ahead and get started. Now, if you have questions, please pop them in the chat. I'll just see if I can open the chat on the side here so that if you have questions, just type them in on the chat, and just try to also make sure that your microphone is muted, because otherwise it makes it difficult for other people who are watching this later on, and I'm recording and I will publish it to YouTube. So I'm going to talk to you about a case that presented to me when I was an intern back at the Animal Medical Center in 1990. So that would have been 25 years ago. Please tell me it's not 35 years ago. No, 25 years ago, 30 years ago. 2.5-year-old Labrador that presented for a 4-day history of left hind limb lameness. We couldn't identify any specific area of pain. And so we did a complete physical examination, but unfortunately not complete enough. We did radiographs of just about every joint we could find in the hind leg, and just could not find anything wrong, and spent several $100s of the owner's money on sedation and radiographs and everything. And then on a more complete physical examination, we found chewing gum stuck between the dog's toes, and trimmed out the chewing gum, and the dog was completely sound from that point on. So just reminds you to do a complete physical examination whenever you're examining a patient with any kind of lameness, and specifically hind limb lameness. So going forward, so I'm going to talk to you about decision-making in hind limb lameness, lameness examination, and some other stuff. Again, if you have questions, please just post them on the chat. And if I don't respond to your question soon enough, you can unmute yourself, yell at me, tell me to answer your question, and then mute yourself again. So the first thing that I want to point out is this was a Vet Clinics in North America paper that was published in January 2001. And what it showed what it said was that cranial cruciate rupture should be assumed to be the cause of hind limb lameness in any dog until proven otherwise. And so that's going to be our most common diagnosis in any dog that comes in with hind limb lameness that's mature. We assume cruciate ligament rupture until we can prove otherwise. And so it's the most common cause of hind limb lameness, and it's also the most commonly misdiagnosis in small or mixed animal practice. There are certainly cases that present that have degenerative joint disease in the stifle or in the hip, and they're treated as degenerative joint disease when in fact the cause of the lameness is in fact cruciate disease. And so just make sure that you consider very, very strongly cruciate disease in any patient with hind limb lameness. The other study that was done, a retrospective study, this was 369 patients that presented to a tertiary referral center for total hip replacement. And they found out that 32% of those dogs had cruciate ligament ruptures, even though they presented for hip replacement surgery, and that the majority of those dogs had not had Stifle radiographs. Okay, so in any dog that has hind limb lameness, you want to take your Stifle radiographs to make sure that it doesn't have cranial cruciate disease, certainly any dog that's mature. Can you justify Stifle radiographs in a dog under a year of age? Look, if you find pain in the stifle and maybe cranial jaw, it would make sense. Maybe if you had no signs of stifle pain or effusion and clinical signs attributable to the hip, that would be more consistent with hip dysplasia in an immature dog, and you might be able to forego these Stifle radiographs. Any questions or comments about that? All right, going forward, Your x-ray showed a broken rib, we fix it with Photoshop. Assessing a patient with Hindlimb lameness. So starting off with our Stifle radiograph, and that's not the first thing that we're going to do, but when we're looking at a Stifle radiograph, is everybody confident? Just give me a thumbs up on the chat, or yes or no, in diagnosing effusion in the stifle of a dog radiograph. Okay, so just put in a yes or a no if you're confident in diagnosing effusion in the stifle of a dog on a lateral stifle radiograph. So very interesting. And we get a lot of patients that get radiographs sent to us for Hindlimb lameness, and it's very, very clear that there's effusion, but that has been missed. So what you want to look for on a lateral radiograph of the stifle is this cloudiness. Can you guys see my cursor on the screen? The cloudiness that's underneath the patellar tendon. So all of this area should be black like this, which is the infrapatellar fat pad. But when you have effusion, it pushes the infrapatellar fat pad distally and cranially, and you have this gray soft tissue area. You can also sometimes see effusion caudally back here. And that is almost pathognomonic for cranial cruciate ligament rupture. So if you see effusion in a dog with a stifle lameness that's chronic, it's 95% chance that it's a cruciate ligament rupture. All right, going forward, remember that before you even touch the patient, the list of differential diagnoses can be really substantially narrowed by using history and signalment. And that's something that we overlook, but is probably the most important diagnostic test that we can do is look at the signalment of the patient, which is the age, breed, and sex, and then look at the history. And if you find any of these slides particularly helpful, just take your phone out and take a photo of the screen or do a screenshot. All right, so one key point is remember that clients don't always know which leg their dog is limping on. All right, you come in for a right hind limb lameness and you do a lameness exam and find out that it's the left hind limb. And I've had numerous clients that come to me referred for a left hind limb lameness, and it turns out that it's actually right hind limb and vice versa. So just make sure that you don't take the owner's word for it when assessing either forelimb or hind limb lameness as to which leg is affected. Also remember that just because you have diarrhea doesn't mean you can't have a headache. So you can have two different things going on at the same time. You could have forelimb and hind limb lameness, both hind limbs, so bilateral cruciate ligament disease is common, spinal disease, which can look like bilateral hind limb lameness, those types of things. So just make sure that you do a complete examination in every patient. So going forward, the first thing that we're going to use in looking at our algorithm for determining what the cause of lameness is age. And age is probably the most important signalment factor that we can use. So in young animals, we're looking at congenital and developmental problems, and there are numerous congenital and development problems in dogs, including hip dysplasia, Pennosteitis, aseptic necrosis of the femoral head, HOD, OCD, patelloluxation. Sorry, I put patelloluxation there twice. I'm not sure why. Maybe it's because it's really important. Young dogs can also have trauma. And interestingly, younger dogs are more likely to have traumatic cruciate ligament rupture, whereas older dogs are more likely to have degenerative cruciate ligament rupture. And when you see trauma causing cruciate ligament rupture in immature dogs, often they'll have an avulsion fracture where there's a piece of bone that's pulled off the tibial plateau, and you'll see it floating in the joint. You can also have septic arthritis in young dogs. Now, just by a yes or no, how many of you have diagnosed Pennosteitis radiographically and would be comfortable with making that diagnosis? Just give me a yes or no on the chat. So we've got a few yeses, a few no's. So Pennosteitis, if we look at this lateral radiograph of the femur here, you have this patchy density in the medullary canal. And it's really important if you're suspicious of Pennosteitis is that you compare it to another leg. So you radiograph the other side. And again, we can see this medullary patchy density. The other thing that you can often see is a little bit of periosteal reaction adjacent to the patchy density. So this is Pennosteitis in a dog. Most commonly occurs in German Shepherds, but can occur in any breed. Most often under the age of 3, but we've diagnosed it up to the age of 7 before in one patient when I was a resident. Okay, going forward, mature dogs are more likely to get degenerative joint disease. Degenerative joint disease can be caused by cruciate ligament rupture, meniscal disease, hip dysplasia, patella luxation, Achilles mechanism disease, lumbosacral disease, degenerative joint disease secondary to other causes. Always remember neoplasia. And if you've got a dog that's mature over the age of kind of, 2 or 3, actually any age dog, if you're suspicious of a cruciate ligament rupture, you're always going to take radiographs because any age dog can have osteosarcoma. Remember that there are 2 different peaks, which occur at 2 years of age and 8 years of age. And it would be very embarrassing and unfortunate to do a cruciate ligament surgery on a dog that we hadn't done radiographs on and then find out that it has osteosarcoma when it doesn't improve from its lameness. So this is a dog with a distal radial osteosarcoma, which is medial. This would probably be a parosteal osteosarcoma, which is very peripheral out here. And we know that with osteosarcoma, the prognosis is most dependent on the size of the tumor. And so this would be a very small tumor, which would potentially have a better prognosis than patients that have larger tumors. So osteosarcoma, synovial cell sarcoma, and then also hypertrophic osteopathy is a cause of lameness. And what it causes is periosteal reaction in the metacarpal and metatarsal bones due to a pulmonary or intrathoracic or intra-abdominal lesion, often caused or thought to be caused by vagus nerve stimulation or irritation, which causes this bone proliferation. I'm sorry, I don't have a photo of that, but hypertrophic osteopathy can be a cause of lameness. If you ever see the classic periosteal reaction on the metacarpal and metatarsal bones, make sure you take thoracic radiographs and an abdominal ultrasound. Immune-mediated polyarthritis is an inflammatory condition, also iliopsoas strain, which is kind of a obscure cause for lameness, but if you can't find any other reason, they're often very painful on hyperextension of the hip, and they can also be very painful on direct palpation of the iliopsoas muscle. Again, age, as far as hip dysplasia is concerned, we have to remember that there are 2 different stages of hip dysplasia. There's immature and mature hip dysplasia. Immature is due to pain, or is pain due to stretching of the joint capsule, as well as microfractures on the acetabular rim. And mature hip dysplasia is caused by degenerative joint disease. Both of these are caused by joint laxity. With joint laxity in the immature patient, you're going to have, again, stretching of the joint capsule, and then you're going to have the head of the femur impacting the dorsal acetabular rim, which is going to cause pain. Remember that in a patient that's 7 or 8 months of age that has pain from hip dysplasia, often those dogs are going to improve at skeletal maturity at 12 to 14 months of age because that joint capsule tightens naturally and the joint and the microfractures heal. And so often in a dog with hip dysplasia that's limping at 7, 8, 9 months of age is going to improve at skeletal maturity and then go on and deteriorate again when it gets the degenerative joint disease. Mature hip dysplasia is obviously degenerative joint disease. We're going to have different treatment options for both of these as well. So immature dogs, we're going to think about things like, as long as they don't have degenerative joint disease, think about double pelvic osteotomy, triple pelvic osteotomy, potentially juvenile pubic symphysiodesis if they're under 4 months of age. Whereas mature hip dysplasia, we're thinking about things like conservative management, femoral head and neck ostectomy, total hip replacement, denervation, that kind of thing. Okay, the question is Pennosteitis a self-limiting disease? If not, what's the treatment? Yes, Pennosteitis tends to be a self-limiting disease, although we usually treat them symptomatically with anti-inflammatory medications, even up to gabapentin and rest. Most of them are going to improve within the next couple of months. And there is no specific treatment for Pennosteitis. Just wait until they're skeletally mature and a lot of them will improve. So going back to signalment, smaller dogs have very different diseases to larger dogs. Smaller dogs tend to get a lot of patella luxation. So I've got a quiz question that's a bit of a trick question for you. Small dogs tend to get medial patella luxation. What do large dogs get? Just give me a response in the chat. What kind of patella luxation do large dogs get? And James, I tricked you. So everybody associates lateral with large breed dogs, but actually large breed dogs are still more likely to get medial luxation than lateral luxation. If you have a lateral luxation, it's more likely to occur in a large breed dog, but if you have a patellar luxation in any size dog, it's more likely to be medial. Okay, does that make sense to everybody? All right. So again, small breed dogs, aseptic necrosis of the femoral head, also known as leg calf Perthes disease. Immune-mediated polyarthritis tends to be more common in smaller breed dogs, and distal joints, so that's going to be like your carpus, elbow, hock, and stifle. Rarely do we see it in the hip or in the shoulder joint. Small dogs tend to get thoracolumbar disc disease. They can also get cruciate ligament disease as well. We tend to see the bigger dogs with cruciate ligament disease because we're more likely to be doing TPLOs, whereas in primary care practice, people are happier doing extracapsular suture on small breed dogs with cruciate ligament disease. All right, large dogs tend to get hip dysplasia, OCD of the stifle and hock, that's in the back leg. In the front leg, we can get OCD in the shoulder and in the elbow. Large dogs get lumbosacral disease, Pennosteitis, hypertrophic osteodystrophy, cranial cruciate ligament disease, gastroc tendinopathy, and neoplasia. So there's a question, what is the maximum weight you would consider an FHO on a dog with hip dysplasia? So really good question. Generally, we say that dogs should be under 25 kilograms. However, I've had 30, 35 kilograms dogs where they've got severe hip dysplasia, and basically it's either an FHO or euthanasia, and I've done bilateral FHOs on those dogs, and I've had good results. That's a really nice segue for our VetDojo module on femoral head and neck ostectomy, which will give you some hints and tricks on how to get better results with your femoral head and neck ostectomies. So it's vetdojo.com. And that is our least expensive module. I think it's $49 US. It's our most popular module, and it gives you some really nice hints on how to get better results with your FHOs. Question about how do we diagnose immune-mediated polyarthritis? So what they look like clinically is that they look like they're walking on eggshells. So they're very, very tenuous and tender on their gait, and they're very stiff and stilted. And then what you'll see is pain on the smaller distal joints. And what you do is you do a joint tap, ideally on multiple joints. And what you'll see is neutrophils on the joint tap in the range of, I think it's about 70 to 100,000 neutrophils per microliter. And it's slightly lower count than you would get with septic arthritis. But if you have a neutrophilic arthritis that's present on more than one joint, that's almost by definition immune-mediated polyarthritis. Could you potentially have septic arthritis in multiple joints? Probably, but it's pretty unlikely. Okay, so we're looking for walking on eggshells, stiff, stilted gait, generally small to medium dog, pain on the joints, and then you tap a joint and you get, or you tap multiple joints and you get neutrophilic inflammation. That's going to be your immune-mediated polyarthritis. Now, as far as treatment is concerned, first thing we do is we want to make sure that there isn't evidence of neoplasia or something like that somewhere else, because that can stimulate the development of immune-mediated polyarthritis. And then we're going to treat them with corticosteroids. And usually I go with a high-dose immunosuppressive course of corticosteroids at 2 milligrams per kilogram of prednisolone for 2 months solid, and then taper. And that's going to cure about 60 to 65% of those patients. And then another 30% we can fix using adding something else on, like azathioprine or something like that. And I'm not an expert at all of those other immunosuppressive medications. I do know that my second wave is usually azathioprine after prednisolone, and we can fix probably 90 to 95% of those patients. But you want to keep them on the high-dose steroids for an extended period of time to really knock that back. So 2 months at least on high-dose steroids, and then if it recurs or recurs when you discontinue the steroids, then you need to either reintroduce the steroids or consider starting them on another immunosuppressive drug. The other thing that you can measure is C-reactive protein. We've got it available to us in Australia. I'm sure that it's available in some other countries as well, but C-reactive protein is a non-specific indicator of inflammation, and you can use that to track the response to treatment. with immune-mediated polyarthritis. So if you measure C-reactive protein to start with and it's elevated, you can track that to see what your response to therapy is. All right, so we've looked at size of dog, age of dog, duration and time course of clinical signs is the other one that's really important. So generally, things that are slowly progressive are going to be hip dysplasia, LS disease, some tumors, although remember that you can have acute exacerbation of any one of these three conditions with either trauma, overuse, overactivity, that kind of thing. Intermittent and progressive, we tend to think of cruciate ligament disease, maybe patella luxation. And if you have something that's acutely progressive, you can have, like if you have a dog, I had one come in this morning that had chronic grade 2 patella luxation, cruising along really well, 15 years of age, and then suddenly it became acutely lame about a week ago, and I palpated that dog and it had a cruciate ligament rupture. So don't forget that, so don't get blinders on. Just because you see patella luxation, don't forget that it could also have a cruciate ligament rupture, and in fact, that occurs with some frequency. Neoplasia can also do that, particularly with a pathological fracture. The other thing that if you have a dog that's kind of 7 or 8 years of age, large breed dog running around in the garden and suddenly pulls up acutely lame with a broken leg with no history of trauma, always think about a pathological fracture in that situation. When you take your radiographs, don't just look at the glaring distal radial fracture, look for very subtle signs of periosteal reaction, bone lysis, those types of things that would be more indicative of a pathological fracture due to osteosarcoma. So please don't forget that. If you have an older dog that's running around in the garden, acutely becomes lame because it snapped a bone, look really closely at the bone ends to see if it's got evidence of neoplasia. All right, so another really important thing is the effect of exercise and time of day. So if you have a patient that's worse with exercise and improves with rest, think of cruciate ligament disease, immature hip dysplasia, lumbosacral disease. If it gets better with mild exercise, think of degenerative joint disease due to hip dysplasia or something like that. So dogs with just purely degenerative joint disease are often going to warm out of their lameness, whereas if they have some kind of underlying cause like cruciate ligament rupture, immature hip dysplasia, LS disease, they're going to get worse with exercise and improve with rest. All right, look really carefully for neurologic deficits. Urinary and fecal incontinence in a dog with hind limb lameness is consistent with lumbosacral canal stenosis or a spinal tumor. Also with lumbosacral disease, once they get urinary and fecal incontinence, that is a poor prognostic indicator. So those dogs are less likely to improve with medical or surgical management. If you have a dog that's knuckling, indicative of CP deficits, think of lumbosacral disease with foraminal compression. And look at, notice how I've divided lumbosacral disease into canal stenosis and foraminal compression. So canal stenosis is due to a bulging disc. I'll go into this in more detail later on. It's due to a bulging disc, and that's going to cause your urinary and fecal incontinence, maybe a little bit of hind limb deficits, whereas foraminal compression, so on the sides where the nerve roots are traveling through the intervertebral frame in between L7 and S1, are more likely to have hind limb pain and knuckling. Also with knuckling, think of degenerative myelopathy. Remember that dogs, so hip dysplasia can happen commonly in dogs that have both, that also have degenerative myelopathy. So think about German Shepherd, 7-year-old dog comes in with evidence of hip dysplasia. Don't forget to check it for conscious proprioceptive deficits because it could also have LS disease, also have degenerative myelopathy. So you don't want to do a $10,000 hip replacement and then find out that it has neurologic problems from which it's going to deteriorate further. Think about nerve root tumors and disc disease as well in dogs that are knuckling. Very suggestive clinical sign in a dog with nerve root tumor is pain in the groin or inguinal region. So if you reach up and grab them in the groin and they scream out in pain, that's consistent with nerve root tumor. Same thing applies with a brachial plexus tumor. If you grab them in the axilla and really pinch up into the axilla, they'll go through the roof. That's sign of brachial plexus nerve root tumor as well. All right. Yelping is usually due to nerve root impingement. Rarely do we see dogs that have just orthopedic disease, yelp, and pain. Happens occasionally, but very uncommonly. Difficulty rising is often due to hip dysplasia or LS disease. Occasionally, you'll have bilateral cruciate disease that can cause difficulty rising as well. All right, so lameness examination is a subjective assessment of a patient's gait. And so that's one of our most important diagnostic tests in determining which leg is affected. And I'll show, this is done both at a walk and a trot, and trotting often exacerbates the lameness. You want to observe the patient from behind, walking away from you in a straight line, and then walking toward you in a straight line. And then you also want to look at both sides, walking in one direction, walking the other direction. So specifically for hind limb lameness, watching from behind the patient is a little bit easier to pick up the side of the hind limb lameness, but make sure you do observation from all four sides, behind, left, right, and from the front. Confusing lamenesses can be exacerbated by walking a patient up or down the stairs. So hind limb lameness is going to be exacerbated walking up the stairs. Forelimb lameness is exacerbated by going down the stairs, where they have all their weight concentrated on that limb. The other thing that you can do is you can place your hand over the ilial wings, and you can sometimes palpate luxation and reduction of the hips in a patient, particularly with early or immature hip dysplasia. So when a dog is lame, they may try to spend less time on that leg, which means that they're going to have a shortened stance phase. So when you watch them walk, they're going to spend half a second on the good leg and a third of a second on the bad leg. They're going to try to apply less pressure on that leg. And so the way that you would measure that objectively would be with ground reaction forces, using a force plate or a pressure plate. They're going to try to protect a painful joint by decreasing the spontaneous range of motion and angular velocity of that joint. Does that make sense to everybody? So if a stifle is painful, it's going to try to reduce its own range of motion in that stifle, and it's also going to try to reduce the speed with which it moves that stifle. So that's your angular velocity. And it's also going to walk with its affected leg abducted. So it's trying to take it away from the center axis in an effort to try to put less weight on it. All right, so one of the most important diagnostic tools that you have, and everybody carries one around with them, is your phone. So you want to video them from behind and from the front, and that's going to really exacerbate some lamenesses. And if you have a fancy phone that has slow motion, that's even better. So this is a patient that we can see as it's walking. So this is a left hind limb lameness. So watch what it's doing. What a dog does with a hind limb lameness is that if you watch the pelvis is going to be more mobile on the affected side than on the unaffected side. So let's watch this. See how that left hind leg is going up and down? And I'll just come back and I'll move it really slowly. So it's dropping steady on the right leg and then drops on the left. See how it goes up and down on that left leg? So that's a sign of a left hind leg lameness. And if you have slow-mo on your phone, that's a much better way to look at it. And I will have this uploaded on YouTube, and so you can watch it as well. All right, and when they're walking quickly, it can be tricky to pick up a lameness. So let's just go back and slow that down a little bit. So I'm just going to move that across. So steady on the right rear and drops on the left rear. So see how great that is? Using your phone, you can really slow things down. And if you have slow motion on your phone, it's even better. So what it's doing by dropping its pelvis down on that side, it's just trying to reduce the amount of weight it's bearing on the affected side. So let's go back and speed that up again. When it's fast, now that you know what to look for, you can pick it up. But when, the first time you look at it, and especially if you're just watching the dog out on the street, it can be really easy to miss which leg's affected. So pull your phone out and record it, preferably on slow motion, and that'll help you pick that up. So that's a left hind lameness as well. So this one is more subtle. So let's go back and try to do it in slow motion. I believe this is left hind leg as well. See how it dropped down there? Drop down on the left and straight on the right, and then down on the left. See how it dropped again on the left-hand side? And so let's speed it back up again. See that? So subtle, but again, much easier to pick up when you're using a telephone. All right, so there's another test which is really valuable. It's positive in about 85% of dogs with cruciate ligament disease, and that's a sit test. And what they do is when you take a normal dog, they're happy to sit squarely on their haunches, whereas when you take a dog with cruciate disease, they're reluctant to sit on their haunches, and they're going to sit with the affected leg to the outside. So we can already see that this dog's got a left hind limb lameness. I should have called this lecture left hind limb lameness in dogs. So you see how he's sitting to the side, and he won't sit comfortably on his haunches, so he's putting his leg out to the side. Okay, and then this is a dog that's unwilling to stand up. So just really tenuous, and that's going to be, in a large breed dog anyway, LS disease or hip dysplasia. So look how he puts all his weight in the front and basically just lifts up his back legs. I'll play that again for you. So he's really just trying, it's almost like he's a two-legged dog. So two legs in the front are working, the back legs are not working. So really just shifts his weight completely forward, cantilevers his head all the way out there so that he can put less weight on his back legs. Okay, so kinematics is something that's really cool. We don't have it here. I don't know if anybody in Australia has it. I know in the US, a lot of laboratories in vet schools have them. But what they do is they put pieces of tape, white tape on each of the joints, and then they've got a computer that automatically senses where these places are. And then you can do things like measure angular velocity and things like that. So kinematics is the science of describing the motion of objects, and it quantifies positions, velocities, accelerations, and angles of anatomical points, segments, and joints in space. And so basically what we're doing is objectifying things that we look at subjectively on a lameness exam. UC Davis has an amazing laboratory. This looks like they're filming, like when they do cartoons and they have actors that are going to act out fight scenes and things like that, that then are going to be turned into animation. That's basically the same thing that we're doing. So really, really cool in the way that it makes objective things that we subjectively look at on a lameness examination. This is a study that they looked at the angular velocity in the stifle of dogs that had cruciate ligament ruptures compared to dogs that were normal. And they found that the angular velocity stifle angular velocity in a normal limb was much higher than in a lame limb. So that's really cool. And things like foot elevation was the same for the most part, between the normal limb and the affected limb. So how high off the ground the foot came. But when you looked at angular limb velocity, we can see that it was decreased in the affected limb. Also things like range of motion. So this is when the dog is trying to reduce its own range of motion of the stifle when it walks in order to protect itself from pain. Also, we've got a reduced stride length. So this is where it's spending half a second on the unaffected normal limb and a third of a second in the affected limb. Again, these are all just objective numbers that we've put on things that we observe in clinical lameness. All right, we want to make sure that we do a neuro examination, particularly if there's any evidence of ataxia in the back legs. So conscious proprioception is the first test that I tend to do. We can also look for spinal reflexes. Make sure that when you're doing conscious proprioception that you have your hand up underneath the back end of the dog, because so when you have the back end supported and then you flip the toes over, that's going to be more sensitive than just flipping the toes over. If you flip the toes over and the dog falls over to the side and then it rights itself, That's not a very sensitive diagnostic test. What you want to do is support the back end and then just flip the toes over so that it's not falling over. So all they're sensing is the fact that their toes are in the wrong place. Again, spinal reflexes, we're also going to look for pain on palpation of the thoracolumbar spine and the lumbosacral junction. So checking reflexes. Now, this time, just for fun, I'm also going to hold this soccer ball. All right, physical examination. We want to palpate for muscle asymmetry and atrophy. And then one of the biggest diagnostic tests that we can do for cruciate disease is to palpate medial buttress on the stifle. And the way that you do that is you face the dog away from you just like this, and then run your fingers around, so around the front of the patella, around the front of the stifle, and then use your fingers to palpate the inside of the stifle. And what we're looking for is a big bump, mostly in the proximal tibia, but a little bit on the distal femur, and that indicates chronic craniocruciate ligament insufficiency. Medial buttress is more reliable than cranial drawer for chronic cruciate disease. So virtually 100% of dogs with chronic cruciate disease are going to have medial buttress, whereas only about 50% are going to have cranial drawer instability. We also want to palpate the patella. Where is the patella? Where is it tracking? And then also, can it be luxated? Make sure that when you try to luxate the patella, number one, they're not weight bearing at the time. And number two, you internally and externally rotate the hock relative to the stifle. Also, we're looking at common calcanean tendon, so we're going to palpate that down there to see if there's evidence of chronic rupture of the common calcanean tendon or superficial digital flexor luxation. So Doberman pinschers frequently have bilateral gastroc tendon rupture or avulsion, and that is thought to be a degenerative condition rather than traumatic. When you're doing an orthopedic examination, it generally requires sedation, and I prefer acepromazine and an opiate like butorphanol or morphine over Domitor or dexdomitor. I think that dogs that get Domitor or dexdomitor are too anesthetized. They're not going to respond to pain. Whereas ACE and morphine, methadone, oxymorphone, something like that, they're still going to respond to pain, but they're going to be nice and quiet for radiographs and a complete orthopedic examination. Be methodical. Work from distal to proximal. Don't miss any chewing gum between the toes. Check the toes carefully for pain and foreign bodies. So we're going to flex the toes and extend the toes, palpate for any evidence of pain. You want to palpate the joints for swelling, range of motion, crepitus, pain, and medial lateral instability. So medial lateral instability, we're looking at collateral ligament damage. Range of motion is going to be indicative of degenerative joint disease. Swelling is more for either degenerative joint disease or an acute problem. Crepitus is going to be for like meniscal injury or degenerative joint disease. And one of the most important diagnostic tests is detecting pain on hyperextension. So pain on hyperextension is really reliable for identification of the source of pain and lameness in a dog. Remember to attempt to luxate the patella while internally and externally rotating the tibia, and make sure that they're non-weight bearing at the time that you're palpating the patella. We have somebody saying good night to us because it's bedtime in Canada. What time is it here? So it's probably about midnight in Canada, maybe 11 p.m. 10? Dylan, are you saying 10 p.m.? Right. Palpate the groin for pain, so we're looking for nerve root tumors. Also palpate the long bones for pain and swelling, which would be indicative of either a bone cancer or Pennosteitis. So long bone pain is kind of the classic clinical sign for Pennosteitis. So this says why science teachers should not be given playground duty. All right, so just a quick discussion about lumbosacral disease. So lumbosacral disease is a numerous different things that can occur simultaneously. I didn't really understand LS disease until I started doing a lot of CT scans on these patients and recognizing the CT changes that we're getting. So one thing that's interesting is that a lot of dogs with LS disease will have a transitional vertebrae or malformation of L7 or S1. So this is an example where this is kind of halfway. So on one side, which would be the right side, it's L7, and on the left side, it's S1. So that's a common with LS disease. You can have type 2 disc protrusion. You can have articular facet arthritis, and I'll explain that in a little bit more detail in a minute. Subluxation and telescoping of the sacral lamina. Compression either dorsally, ventrally, or in the foramen. And you can also have reduced circulation of the radicular vessels causing radicular ischemia and edema. If you have a telephone, take a photo of this slide because there's a lot of important stuff here. And LS disease is hard to diagnose and hard to pick up clinically. And it's something that's, I think, really underdiagnosed in a lot of patients. So always be thinking about LS disease when you're looking at patients with hindlimb lameness. So normal anatomy of the lumbosacral junction. This is a CT scan. It's a hinge between the pelvis and the vertebral column, knowing that the L7 is obviously part of the vertebral column, and the S1 is attached to the pelvis via the sacroiliac joints. And so normal anatomy, you've got L7 body, you've got the sacral body, you've got a disc, which is made up of the annulus, fibrosis, and the nucleus pulposus. Here are the nerve roots coming out here. You have the interarcuate ligament up there, spinous process, sacral lamina. On the axial slice, we've got the intervertebral foramen, which is between L7 and S1. Got our nerve root sitting here, sacral lamina up there. This is the articular facet. Ilial wing is out here. And then you can see the L7 nerve root traveling through the intervertebral foramen. Anything that's black like this on a CT scan, if it's dark black like this, it's air. If it's kind of a blacky gray, charcoal gray, that's going to be fat. Okay, and so if you have perineural fat traveling through the foramina and in the lumbosacral junction, that means that there's unlikely to be a lot of compression there. So this is a diagram of the areas that are affected with LS disease. So we've got a bulging LS disc, which is like a type 2 degeneration. We've got foraminal stenosis, which is on the side here, so it's beside the nerve roots. We've got nerve root compression from this LS disc and also thickening of the interarticulate ligament and joint capsule. And then you can have ventral subluxation of the sacrum. So you can imagine that this would be quite painful. I have an L5 S1 spondylolisthesis in my own back, which means I've got a 1 centimeter step between my L5 and S1. Just gets exacerbated whenever I lift heavy things. That's my excuse anyway. But I can tell you for sure that this is quite painful, and I do have sciatica and things like that. No urinary or fecal incontinence yet, thank goodness. So this is a normal LS junction. So we've got the perineural fat in here, nice open foramina, no bulging disc. Here's the nerve root sitting right here. Interarcuate ligament is up there, articular facets, and this is a diseased bone. So we can see that we've got a lot of osteophytosis here. We've got a lot of fibrosis in this intervertebral foramen. We probably have bulging of the disc here. We've lost a lot of our perineural fat. And so this dog has definitively lumbosacral disease. Now, we wouldn't treat it based on just this CT scan. We'd have to get the associated clinical signs, which would be pain on deep palpation dorsally in this area here, CP deficits, pain on the back legs, exacerbated by exercise, maybe urinary and fecal incontinence. So you want to look for all those things before we treat it. So this is a lateral or sagittal reconstruction of a CT scan. This is a normal dog here, a little bit of bulging of the disc. The nerve roots are just floating freely in perineural fat. And then when we look at this dog here, we've got bridging spondylosis ventrally, big bulging disc here, a little bit of telescoping, and really severe compression of those nerve roots that are coming up here. Now, if you have MRI, MRI is better for diagnosing LS disease than CT scan. We don't have MRI here, and I feel like we pretty successfully diagnose and treat it. But obviously, if we had an MRI, we would be doing MRIs on these dogs rather than CTs. So this is a 3D reconstruction of a normal and an abnormal LS joint. So this is the articular facet right here. The foramen is made up dorsally and cranially by L7 and ventrally and caudally by S1. And so the nerve root travels right through that foramen right there. This is a patient with severe LS disease, so we've got a lot of degeneration here. Basically, that foramen is completely obliterated by osteophytes and fibrosis. All right, so how do we treat LS disease? Usually we start with a course of epidural cortisone. We administer 1 milligram per kilogram of depomedrol injected into the epidural space at time 0, 2 weeks, and 6 weeks. And the literature suggests that we can cure about 50% of dogs with just epidural cortisone, and we can improve about 75% of dogs with epidural cortisone. If epidural cortisone is not successful or inadequately successful, the next thing we do would be a distraction fusion. And by doing that, what we're doing is we're putting screws in the lamina of L7 and the sacral lamina here, distracting it open, and then putting bone cement on it. And we can fix about 85–90% of dogs with distraction fusion. And that's the end of my presentation. So if you guys have questions, you can either post them on the chat. I'll stick around and listen for a little while, or you can just speak out and unmute yourself and ask the questions. But thank you very much for watching, and I will post this on YouTube as soon as Zoom finishes reformatting the video. Any questions about anything case related or... So there's a question, can you do steroid injection for ACL? Steroid injection for ACL is going to reduce the pain, but it certainly is not going to do anything for the instability. So I think that you've got to do something either more definitive in terms of surgical treatment or repair, or something more appropriate for long-term, which is going to be non-steroidal anti-inflammatory drugs, weight loss, cartilage protectants, and exercise modification to reduce high-impact activities. Any other questions or comments? It's kind of a hodgepodge of hind limb lameness. So opinion on PRP. I don't use a lot of PRP. There are surgeons in our practice, James, Ben, Alex, do use PRP. Often they use it in combination with stem cells. I use a lot of stem cells because I think that there's quite a bit of objective literature that supports the use of stem cells with degenerative joint disease. I'm not aware of as much objective literature with PRP, but I think that the guys that use it have found it to be quite helpful, and particularly with or in combination with stem cells. Laser therapy, again, I think that there's maybe some evidence for degenerative joint disease. We don't have laser here. It's probably one of the ones that maybe has more objective evidence behind it. Laser and acupuncture. I think that a lot of the nutraceuticals like cartrophin injections and stuff like that, I think that there's less objective evidence. What we often hear is that some clients think it's helpful, and some clients think that it's not helpful. Question about treatment for rupture or degenerative joint disease of the gastroc tendon. And so the treatment for that is going to be, if it's acute, then it's going to be primary repair. If it's not acute, what we still find sometimes is that if you put them either in a non-weight or a hyperextended splint, and people can inject sometimes either PRP or stem cells into the tendon, that can be helpful as well. And the other thing that I've done is occasionally arthrodesis for those guys as well, with reasonable success. There's a question, how frequently do you find lameness from the tarsal joint without a history of trauma? So tarsal joint lameness, if it's non-traumatic, you can have just degenerative joint disease. The other thing that we see is OCD in the hock, and OCD causes horrendous lameness, and that is the joint that has the least success with surgical debridement of the cartilage flap. In those cases, I'm just as likely to recommend arthrodesis or fusion of the hock joint or of the tarsal joints rather than debridement of the OCD lesion. Thoughts on braces for ACLs? So I think that the problem is getting the brace to stay on. If you have the perfect long-legged lean dog that you can get a joint or a brace to fit and stay on, I think the success rate is probably about 50%, maybe a little bit better than conservative management, but still not as good as surgery. Infiltration with steroids. I assume that you're talking about steroids for gastroc tendon avulsion. I have heard of people doing that before. Otherwise, if you're doing steroid injections just for degenerative joint disease, I think that that's probably not great, and you're going to cause progression of degenerative joint disease without fixing any of the underlying problems. Epidural steroid injections in disc bulging disease, any help? So we have done them for cervical disc ruptures where owners have been either reluctant to go to surgery or because it's a very lateralized disc and maybe of some benefit. I honestly don't have a lot of experience with that. Any other questions on hind limb lameness or anything else? I'll stick around for a minute. Nothing coming up yet. All right, so make sure that you subscribe to our YouTube channel. And also, if you're interested, have a look at VetDojo.com. There's some free material there. There's also some paid material. There's a subscription plan, which is $15 US per month, which gives you access to all of our inside documentation, which includes all of our standard operating procedures, disease descriptions, discharge instructions, medication descriptions, all kinds of things. So if that's of interest to you, please sign up and sign on. All right, I'm going to go ahead and end the live stream. So thank you very much for watching. You can send any questions that you have via message on vetdojo.com or post them as comments on the YouTube channel, although I tend not to monitor the YouTube channel as closely as I do VetDojo. So thanks again for watching. It's great to see everybody's faces and see names that I haven't seen in a long time. And hopefully we'll get to these with a little bit more regularity. Also, hopefully a bit more live streaming as well.